Hello, and welcome to my evidence-based research presentation on the clinical use of the Bispectral Index Monitor to prevent intraoperative awareness. My name is Bethany Corke, and I am a student nurse anesthetist at the University of South Florida. Intraoperative awareness can be defined as an occurrence in which a patient becomes conscious during a procedure performed under general anesthesia and subsequently has recall of these events. Although this is a rare occurrence, about 1 to 2 per 1,000 cases, the emotional and psychological effects an intraoperative awareness episode can induce on the patient can be extremely distressing. It has been noted that 70% of patients who experience intraoperative awareness suffer from post-traumatic stress disorder. Any patient undergoing general anesthesia has a risk for unintentional intraoperative awareness or recall. However, there are specific risk factors that have been identified that put patients at an increased risk for awareness. These risk factors are a history of awareness, hemodynamic instability, pediatric and elderly patients, chronic use of opioids and anti-anxiety medicines, substance use disorder, tobacco and alcohol use, cardiac surgery, cesarean sections, trauma surgery, neurological procedures, difficult airway management, surgery occurring at night, and the use of neuromuscular blockade. The Bispectral Index Monitor is an objective monitoring tool that reads and analyzes electroencephalogram EEG waves of patients under general anesthesia and computes a number based on the patient's level of anesthetic depth and hypnotic state. The BIS monitor allows providers to titrate their anesthetic depth based on these values. However, there has been conflicting studies and clinical opinions from providers on the reliability of the BIS monitor. Currently, there is a large discrepancy among hospital settings on when and if the BIS monitor should be used. The last clinical practice guidelines on the use of the BIS monitor during general anesthesia for preventing intraoperative awareness were released from the American Society of Anesthesiologists in 2006. Thus, there is a need for updated clinical practice guidelines to address if and when the BIS monitor should be used on surgical patients undergoing general anesthesia. My evidence-based practice question is, in adult surgical patients, how does the use of the BIS index monitor versus not using the BIS monitor affect the rate of intraoperative awareness within the hospital surgical setting? And under what protocol should the BIS monitor be routinely used? My patient population will be adults receiving surgery in the hospital under general anesthesia via inhalational and/or intravenous anesthetics. The problem is that there is no set standard on the use of the BIS monitor for avoidance of intraoperative awareness. The intervention is the use of the BIS monitor throughout the entire surgical case. The comparison is the use of the BIS monitor for monitoring for intraoperative awareness versus end-tidal anesthetic concentration, or just having clinical patient signs, such as changes in heart rate, blood pressure, sweating, tearing, and tachypnea. The outcome is a decrease in the intraoperative awareness with the use of the BIS monitor. This will be evaluated by postoperative Bryce questionnaires. Research analysis will identify if the data supports the benefit of using the BIS monitor for all surgical patients, or those who fall into high-risk categories, or to not use it at all. This will be determined by how much of a decrease in the incidence of intraoperative awareness is seen in the data in using the BIS monitor versus not using the BIS monitor. The new protocol will be adopted within 1 month and data evaluated at 6 months. A literature search of the online Sinhal, Cochrane, Dynamed, Google Scholar, Medline, Ovid, PubMed databases through USF was conducted. The AANA website was referenced for the current position statement on intraoperative awareness, and clinical practice guidelines from the American Society of Anesthesiologists was used as a resource. The following key search terms were used in the databases: BIS monitor, intraoperative awareness prevention, unintended intraoperative awareness recall, intraoperative awareness bispectral index, intraoperative awareness monitor, and intraoperative awareness general anesthesia. The search was limited by using the following filters: full text, peer-reviewed, English language, and articles published within the last 10 years. 34 articles were reviewed, and 8 were included in this review. The articles were eliminated if they did not involve the use of the BIS monitor, involved sedation, not general anesthesia, or if they lack sufficient evidence level. The first article in my literature review is a randomized controlled trial from 2011 in the use of the BIS monitor on patients over the age of 18 at risk for intraoperative awareness. It is a Level 1 Quality B article. In this study, 49,000 surgical patients were screened. 5,809 patients were included in the trial. 2,907 of these were in the BIS group, and 2,902 patients were in the end-tidal anesthetic concentration control group. 5,413 patients completed postoperative interviews at 72 hours and 30 days using the modified Bryce questionnaire. The results did not show that the end-tidal anesthetic group was associated with an increased postoperative mortality or increased use of anesthetic agents. The trial did not demonstrate the superiority of the BIS protocol over a standard end-tidal anesthetic concentration monitoring protocol for the prevention of intraoperative awareness. A protocol based on the use of both the BIS and end-tidal anesthetic concentration alerts would perform better than any one of these alone. The limitations were that the study was only on inhaled anesthetics. Thus, the results cannot be extrapolated to total IV anesthesia. Statistical analysis stated that 6,000 patients were needed to provide an 87% power. This was not met. It was not identified if nitrous oxide was used, which interferes with the validity of the BIS monitor. The second article is a Level 3C non-systematic review from 2016 that looked at 68 articles and found the use of the BIS monitor provides a clear advantage for guiding administration of anesthesia. It helps improve outcomes and minimize postoperative complications. It reduces costs and lowers rates of morbidity and mortality due to surgical interventions. Patients should be evaluated for risk factors for intraoperative awareness, and the use of the BIS monitor should be based off the presence of these risk factors. Total IV anesthesia is an area that the BIS can be helpful due to a lack of a calculated anesthetic gas minimum alveolar concentration MAC value. The limitations of this article were that it used articles and studies that dated as far back as 2001. No statements were provided on the method of appraisal or articles used in the review. Only the PubMed database was used. There was not a rigorous inclusion and exclusion criteria provided. No flow diagram of the studies or mention of the demographics of the studies was provided, and no limitations section provided by the author. The third article is a Level 1C randomized controlled trial from 2012 that compared 18,836 total surgical patients over the age of 18 getting general anesthesia with volatile or intravenous anesthetics. This trial was only included patients who were not at an increased risk for intraoperative awareness. The authors used a modified Bryce questionnaire 28 to 30 days after surgery via phone to identify patients who developed intraoperative awareness. The trial found that a difference between BIS and anesthetic concentration protocols in reducing the incidence of definite intraoperative awareness could not be found. By post hoc analysis, the BIS monitor may play a role in reducing intraoperative awareness compared to no intervention. The BIS protocol in this study was not associated with reduced recovery time or reduced incidence of nausea and vomiting compared with routine care, and the BIS protocol was not shown to reduce anesthetic drug need. The limitations were that the sample size was not even due to technical difficulties in the BIS monitoring group. 3,384 patients in the BIS group were not monitored. Post-hoc analysis revealed that 102,951 patients in each group would be needed to detect a difference between the two interventions. The study did not say what the average BIS score was kept at while using the BIS monitor. Other aspects of anesthetic care, like the use of benzodiazepines, was not standardized between the two groups, and it was noted that the study was terminated because of futility. The fourth article is an Australian Level 1B randomized control trial from 2004. The trial used 2,463 adult patients receiving general anesthesia under muscle relaxation who had at least one risk factor for intraoperative awareness. Patients were randomly allocated to BIS group or a routine care control group, and patients were assessed by a blinded observer for awareness at 2 to 6 hours, 24 to 36 hours, and 30 days. The trial found that the BIS monitoring reduced the risk of awareness by 82% in high-risk adult patients undergoing general anesthesia with muscle relaxation. BIS monitors had little effect on the time needed to recover from general anesthesia, as measured by eye-opening, and no measurable effect on the risk of postoperative complications. The number needed to treat to avoid one episode of intraoperative awareness in high-risk patients was 138 patients. The limitations were that the study did not say what the average BIS score was kept at while using the BIS. It just states that between 40 and 60 was the goal. Some evidence suggests that anesthetists treated patients differently if they were allocated to the routine care group, because higher doses of Versed and propofol were administered to this group, suggesting there was concern about awareness. Small sample size compared to other studies. Nitrous oxide was used in both groups, which is known to interfere with BIS values. The study is a little old, from 2004. The type of questionnaire to evaluate for intraoperative awareness was not listed or described, such as we don't know if they used a Bryce questionnaire or a different type. And the study was funded by Aspect Medical Systems, which is the company that makes the BIS monitor. The fifth article is a Level 1B systematic review and meta-analysis from 2017 that looked at 17 randomized controlled trials, and it included 10,761 patients. The review found that the BIS monitor showed benefits by reducing extubation time, reducing orientation to time and place, reducing time to leave operating room, and reducing time spent in the PACU. The studies also showed there was a 12% decrease in postoperative nausea and vomiting, a 1% decrease in intraoperative awareness, and a 6% decrease in the risk of delirium in the postoperative patients. There was no difference in outcome to time to hospital discharge, and no reduction of time to eye-opening to verbal command. The limitations were that the demographics of the participants from the study were not clearly defined. The trials they included used both inhaled and intravenous anesthetics. Thus, it is unclear if the type of anesthetic used had a difference on the BIS monitor, and the use of nitrous oxide, which makes the BIS invalid, was not discussed in the literature as an exclusion criteria. The sixth article is a Level 4B clinical practice guideline from the American Society of Anesthesiologists from 2006. The findings were that the consultants and the ASA members agree that only patients considered high risk for intraoperative awareness should be informed of the possibility of intraoperative awareness. Benzodiazepines or scopolamine should be used for patients requiring smaller doses of anesthetics, patients undergoing cardiac surgery, and trauma patients. The consultants and the ASA members disagree that a brain electrical activity monitor such as the BIS is valuable and should be used to reduce the risk of intraoperative awareness for all patients. But the consultants and the ASA members agree that the use of the BIS monitor for the patients with conditions that place them at high risk is valuable, such as those requiring smaller doses of anesthesia, those undergoing TIVA cases, cesarean surgery, and trauma patients. The limitations were that 2 of the 10 members in the task force receive funds or financial interests in a company developing or manufacturing brain function monitors like the BIS. And 54% of the expert consultants disclosed receipt of funds from a company developing or manufacturing brain functioning monitors. And these practice guidelines are from 2006, thus they are due to be updated. The 7th article is a Level 1A Cochrane Systematic Review from 2017. The review included 36 randomized controlled trials of men and women aged over 18 undergoing any type of surgery under general anesthesia, regardless of low or high risk for intraoperative awareness. The findings were that BIS-guided anesthesia can reduce the risk of intraoperative awareness in surgical patients at high risk for awareness in comparison to the use of clinical signs as a guide for anesthetic depth. BIS-guided anesthesia and end-tidal anesthetic-guided protocols may be equivalent in the protection against intraoperative awareness, but the evidence is inconclusive. Anesthesia guided by BIS kept within the recommended range improves anesthetic delivery and postoperative recovery from relatively deep anesthesia. BIS shortened the duration of postoperative care unit stay. BIS-guided anesthesia can significantly reduce anesthetic consumption. The limitations were that the anesthesia providers participating in the trials were not blinded to the assigned group. This could induce a learned contamination bias, which involves changing clinical practice in the parallel control or unmonitored group by using the information from the BIS group. The last article is a Level 2C systematic review without meta-analysis. The findings were that protocol-guided anesthesia, this includes BIS and end-tidal anesthetic concentration-guided protocols, decrease the incidence of intraoperative awareness compared with anesthesia guided by clinical signs alone. Both BIS monitoring and end-tidal anesthetic concentration-guided protocols are acceptable in the prevention of intraoperative awareness. They noted that the provider must be aware of the limitations of the BIS monitor, which are that it is not reliable with the use of nitrous oxide or ketamine. It is a 15 to 30 second EEG processing time delay, which may limit the valuableness during induction. Beach chair position decreases BIS values, and the Trendelenburg position increases BIS values artificially. The BIS monitor may decrease total anesthesia consumption, recovery times, and incidence of postoperative delirium. The BIS offers depth of anesthesia monitoring during TIVA when end-tidal anesthetic concentration cannot be measured. The limitations were that the review used articles and studies dating back to 1984. The only databases that were used were 2 databases. Inclusion and exclusion criteria was not stated, there was no flow diagram provided, study limitations were not listed, and the review did not list what type and how many studies were used. The current AANA position statement on intraoperative awareness is from 2016 and states that the anesthetist should consider level of consciousness monitoring for patients at risk for unintended intraoperative awareness. The use of neuromuscular blockade should be minimized if possible, and it is important that the anesthesia professionals carefully assess patients for a risk of unintended intraoperative awareness, engage in the informed consent process and obtain informed consent, remain vigilant, assess anesthesia equipment performance, and monitor for indications of unintended awareness. This is a table from the AANA that lists the risk factors for intraoperative awareness. Evidence from this literature search supports the following conclusions. Patients should be evaluated for risk factors for intraoperative awareness, and the use of the BIS monitor should be based off the presence of these risk factors. The use of the BIS monitor does not correlate with a significant decrease in intraoperative awareness in patients who are not considered high risk for intraoperative awareness. But the use of the BIS monitor does correlate with a statistically significant decrease in intraoperative awareness in patients who are considered high risk for intraoperative awareness. The BIS monitor provides anesthetic monitoring in total IV anesthesia due to the lack of a calculated anesthetic MAC value to guide the anesthetic depth. A BIS index of 50 to 60 correlates with the decreased anesthetic drug consumption, earlier extubation, earlier orientation times in the postoperative care unit, and shorter PACU stay. But a BIS index kept at less than 50 under general anesthesia did not lead to these benefits mentioned above. Clinical recommendations from this research project are that the BIS monitor should be used routinely in patients presenting with risk factors for intraoperative awareness. Total IV anesthesia is an area that the BIS should be used with routinely due to the lack of a calculated MAC value to guide anesthesia depth. When used to guide general anesthesia, the BIS index value should be kept at between 50 and 60. This correlates with the best anesthetic outcomes. Both BIS monitoring and end-tidal anesthetic guided protocols are acceptable in the prevention of awareness with recall, and the provider must be aware of the limitations of the BIS monitor, such that it is not reliable with the use of nitrous oxide or ketamine. It has a 15 to 30 second EEG processing time delay, which may limit its usefulness during induction. The beach chair position decreases BIS values artificially, and the Trendelenburg position increases BIS values artificially. A protocol that is based in the use of both the BIS and end-tidal anesthetic alerts combined would perform better than either one of these alone. The first step in the action plan is to assign roles. The anesthesia department director will be the project leader. A select few of nurse anesthetists will be assigned to be change champions on the unit. Next, identify barriers. Potential barriers to the new protocol may be that it's another step added to the pre-op anesthesia evaluation. It's the use of yet another monitor to the many that we already use, which may contribute to alarm fatigue, and personal anesthesia provider bias and beliefs on the use of the BIS monitor may interfere. But these barriers can be overcome by supplying education to the anesthesia staff on the most current evidence-based research and trials about the use of the BIS monitor to prevent intraoperative awareness in high-risk patients. Next, identify milestones. After the protocol is introduced to the staff, universal implementation of the protocol in the OR should be complete by 1 month. After implementation of the new protocol, data will be collected for 6 months to measure the impact of using the BIS monitor on patients at high risk for intraoperative awareness and all TIVA cases. Then secure support and resources. A meeting will take place with the anesthesia department director and hospital budgeting department to discuss the need for more BIS monitors and electrodes. Although this protocol will increase hospital costs initially due to equipment needs, statistical analysis will show that this cost may be made up for over time by improved patient outcomes. This protocol should lead to decreased anesthetic use, decreased reports of intraoperative awareness, decreased postoperative nausea and vomiting, and quicker PACU discharge. Next, implement the action plan. An in-service will be held with the anesthesia department to include all anesthesiologists and nurse anesthetists on the new protocol with information on which patients are deemed high risk for intraoperative awareness. A new category will be added to the anesthesia pre-op form to help identify and remind the provider to check if the patient meets criteria to be considered high risk for intraoperative awareness. The anesthesia policy and procedures must be changed to adopt the new protocol. Next, evaluate outcomes. A BRICE questionnaire will be used to evaluate patients postoperatively. These results will be compared to our baseline data score on intraoperative awareness before implementation of the BIS monitor. And finally, report outcomes to stakeholders. These results will be presented to the anesthesia department in a quarterly meeting and to the hospital board of directors to further provide support of the new protocol. That is the conclusion of this presentation. I hope you enjoyed my video. Thanks for watching.